Hi again, this is Tom Inge coming to you from Cincinnati, Ohio. Thanks for the opportunity to give this screencast talking about the importance of type 2 diabetes in adolescents today. I've got no relevant conflicts for this presentation. Some little known facts about diabetes in adolescents. Most of these individuals we're talking about have a BMI that is in the severely obese range. A BMI of 35 is pretty average for an adolescent with type 2 diabetes. One of the little known facts is that diabetes for teenagers is actually harder to treat. People don't know exactly why. Maybe it's high-risk lifestyles in the teenagers or in their family members. Maybe it's a lack of immediate risk to their life, so they don't feel a motivation for really taking care of their disease as they should. Or maybe there is something that is different about them from a behavioral, psychiatric, or biological standpoint. What we do know is that there is no weight loss that's typically seen with standard treatment for the diabetes. In fact, as I'll show you in a minute, it's just the opposite. We see weight gain very commonly, even in those who are deriving good benefit from the treatment of their diabetes. Their weight continues to rise, and that really is a problem for them. Here's a slide, for instance, that just shows what happens to the BMI over the course of 5 years in type 2 diabetics, teenagers that were enrolled in the TODAY study. The TODAY study randomized about 700 teenagers to metformin or rosiglitazone, which is a second treatment, or metformin and lifestyle. So 2 drug therapy, 1 drug therapy, or drug plus lifestyle. And what you see is this very steady but slow rise in BMI in most of the groups, but most particularly in the metformin-rosi group. And if that wasn't bad enough, what about the costs? We see that the adults are very focused on this, and that if you have diabetes that's diagnosed at age 50, you can expect to spend a little over $172,000 for lifetime treatment. But what about the younger diabetic? What about the 30-year-old? You can spend almost twice that much, or $305,000. So in surgical terms, for the cost of these operations, we can clearly derive a return on investment benefit equation from offering surgery. Now, what about the 15-year-old? How much will it cost to look after that patient in their lifetime of problems? Clearly, it would be somewhere greater than $305,000. So treatment with the safest drugs fail earlier than would be expected in adults. And let me show you what that looks like. This is a study looking at metformin failure in type 2 diabetes, or metformin treatment of adults in blue or teenagers in red. And we see here that after 1 year, 2 years, and 5 years, the adults, about 20% of them go on to insulin or fail metformin. 52% over that 5-year period will fail metformin in the teenage age group. So again, a very different treatment outcome depending on age. One of the other problems with diabetes in teenagers is that their comorbidities accelerate in the presence of diabetes. High blood pressure and kidney injury, also known as microalbuminuria, increase 3-fold over time, irrespective of diabetes treatment. So you're treating the diabetes, you may even have it under control, and still you have worsening blood pressure, worsening pattern of kidney injury. Same thing goes for dyslipidemia, where you can see increases in the prevalence of dyslipidemia over time, despite, again, treatment within a trial for treatment of type 2 diabetes. In fact, dyslipidemia and chronic inflammation were common in youth or teenagers with type 2 diabetes, and that worsened over time. Type 2 treatment was generally inadequate to control this worsening cardiovascular risk factor. In the final slide, talking about the Today study results, we see that earlier and more rapid deterioration of beta cell function was also identified in youth as compared to adults with type 2 diabetes. No treatment improved or preserved beta cell function in adolescents with type 2 diabetes. Let me repeat that. No treatment that was used in the study improved or preserved beta cell function in those teenagers. So their beta cells continued to deteriorate. What were the baseline predictors of failure? Those who failed most rapidly, higher hemoglobin A1C, as well as already evidence of reduced beta cell capacity at baseline. So these things may be useful for intelligently selecting patients for surgery. So I would propose to you that we have a dilemma right now in both Mexico as well as in the United States. And that is, if the median time to beta cell failure for adolescents who are diagnosed with type 2 diabetes is just under 1 year, there is micro and macrovascular complications that we know increase with duration of type 2 diabetes, as well as increase with lack of sugar control. Then type 2 diabetes may be more virulent, more harmful in adolescents than in adults. So the question is, if long-term health is the goal in these patients, is more aggressive treatment warranted? And what about surgery in particular? These days, we are doing still gastric bypasses, although not as commonly as in the prior decade. We're seeing a lot more sleeve gastrectomies done. The band has all but disappeared from the landscape, and biliopancreatic diversion is simply not practical for most teenagers. What about the data in adults? Randomized controlled trials evaluating surgery for diabetes. What we see here is that there have been more than 500 individuals that have been randomized to treatment for type 2 diabetes, treatment that includes surgery. The lap band, bypass, sleeve gastrectomy, BPD have all been included in the operations that have looked at surgery versus intensive medical therapy. And you can see on the far right here that there, over the course of 12 to 24 to 36 months, there have been a spectrum of outcomes from remission rates after surgery in the 40s to nearly complete, 93%. I'm going to delve down a little bit more into this paper that was published in the New England Journal from the Cleveland Clinic, Phil Shower's group. And that's here, published in March of 2014, 3-year outcomes. They were randomly assigning patients to gastric bypass, sleeve gastrectomy, or intensive medical therapy. And this is what you see. The medical therapy group does lose weight with an intensive lifestyle intervention over the course of 12 months, and then they stabilize. The surgical groups both lose considerably more weight, a 8 to 10 kilograms per meter square drop in their BMI. And that is largely maintained, although maybe a gentle recurrence or regain of weight, as we see in most all surgical studies. They do describe a difference in the weight loss between sleeve gastrectomy and gastric bypass, I might add. In terms of glycated hemoglobin, that is the primary endpoint of this study. They see a drop, again, with medical treatment, and that is a short-lived improvement because over the course of 3 years, they give back a lot of that benefit that was gained initially on the medical therapy. For surgery, you see very parallel lines between sleeve gastrectomy and gastric bypass, both of them with significant drops in hemoglobin A1C on the order of 2.5 to 3 percentage points. So you have medical therapy resulting in hemoglobin A1C values still in the mid-8s, with surgical therapy resulting in a 7% or 6.7% hemoglobin A1C on average. Importantly, how many patients did we get off of injectable insulin? What we see here in the medical group is that you have initially about half the patients that are on it, and even more at the end of 3 years. Whereas in the surgical group, you have about half on insulin in the beginning, and then that number is less than 10% after 3 years. There are certainly adverse events that can be seen with both medical therapy as well as surgical therapy. In particular, after medical therapy, we see a large percentage of the patients, 91% in fact, that develop hypoglycemic episodes. Surgical patients have hypoglycemic episodes as well, although not quite as frequently. Surgical patients, of course, are eligible for bowel obstructions as well as stricture, ulcer formation, and even leak. In the sleeve gastrectomy group over here, there was one. You do see anemias, and anemias even greater in proportion in the sleeve gastrectomy group in this study. So if the predictors of diabetes remission are weight loss, preoperative insulin use, and disease duration, maybe we should be thinking about surgery for diabetes before we go on to beta cell failure and requirement for insulin. Let's look a little bit at the adolescent data. These are a few of the studies that I've been involved with, and looking at gastric bypass, sleeve gastrectomy, and what we see here is a very consistent message that about 90% remission is what has been observed in our studies at either 1, 3, or 8 years after surgery, with very small numbers. Data that's certainly compelling but worthy of repeat. This is that first study that I mentioned, published in 2010 in Pediatrics. It was a retrospective review from 5 centers with 11 patients overall that underwent gastric bypass. There was 1-year follow-up. Most were females and Caucasian. The average time of surgery was almost 18 years of age, spanning 14 to 21. The gastric bypass resulted in a 51 kilo weight loss on average. That's 34% of their BMI. And before the operation, all were on diabetic medications, and afterwards only one was still on diabetic medications. Let me tell you a little bit about their biochemistry now. In terms of sugar control, the glucose has dropped from an average of 143.8 milligrams per deciliter to 84.5 milligrams per deciliter. Insulin values dropped considerably, 44 to 9, and their HOMA percent S, or HOMA percent sensitivity as a gauge of insulin sensitivity, improved from 23 to 125. What about hemoglobin A1C, that all-important measure of disease status for diabetes? 7.3% at baseline, dropping to the normal range, essentially, on average 5.6 at 1-year follow-up. Abnormal fasting glucose was seen as shown here. In 40%, we had glucoses in the greater than 125 range, and 30% glucoses were in the intermediate range, 100 to 124 preoperatively at baseline. At 1 year, most were in the normal range, 88%, with 13% still in the elevated range, none in the diabetic range. There are still questions that remain, though. I think that the response in Hispanics and in other racial and ethnic groups has to be carefully examined and specifically examined. Most of the studies that have been done have looked at results in women and Caucasian women at that. We really do need to see what happens to everyone with these operations and what kind of variability there may be that needs to be addressed in terms of patient management. Proper timing of the intervention in order to provide the best rescue of the beta cell has to be further discussed. And I believe that there is a rationale for basing the therapy on, and the timing of the therapy, on progression of disease before we have beta cell exhaustion. And that can be calculated. Finally, are the benefits only for glycemic control, or will surgery also prevent other end organ damage that's associated with diabetes? And of course, we're thinking about the big four here: cardiovascular events, blindness due to diabetes, or end-stage renal disease due to diabetes. A little known, little appreciated problem that diabetics have are also cognitive disorders. So we are really eager to see whether dedicated studies, prospective studies of surgery for adolescents with type 2 diabetes can answer some of these questions. In conclusion, adolescents with type 2 diabetes face a progressive disease, and many of them have evolving cardiovascular and other evidence of end organ damage. We have abundant, high-quality research now that shows us in adults that greater benefit is derived from surgery than risk. Surgical intervention for adolescents with type 2 likely will provide the greatest opportunity for reversal of their obesity, reversal of their insulin resistance, which drives a lot of other cascading problems with their health, and also, importantly, critically, provide for beta cell rescue. Beta cell rescue will occur with surgery because of a lot of mechanisms by which the surgery works, and will hopefully restore their glucose control for a lifetime. I would hypothesize, in fact, that adolescent bariatric surgery for the type 2 diabetic will result in durable remission of type 2 diabetes, as well as prevention of cardiovascular events when the surgery is used in youth, more so than when it's withheld until later in life. So with that, I'll acknowledge our clinical team and research team, and also NIH and NIDDK for their assistance with funding of our studies. Thank you so much for this opportunity to present, and I'm sorry I can't be there in person to take questions. I trust that my colleagues that are also working in this field in the audience and on the panel will be able to address any questions. Thank you so much. Bye-bye.